Okay, so humor me a little bit. Try to look like you're actually awake. Wave your hands or do something like that. Say, hi, Dr. Friedberg. Hi, thank you for coming. It's wonderful to see you. It's certainly a thrill. So we say, marhaba, salam alaikum. We will try. In 1968, as a young teenager, I totaled my car. Most people roll a car side over side. I rolled mine back over front down the side of a mountain. And when I woke up the next day, I was really kind of surprised I was alive. And I had this vision somehow that the hand of God reached out to me and said, not yet. I have work for you to do. But if you talk like that in the West, you're almost guaranteed a ticket to the insane asylum. At least here, I feel I'm among people who understand, people who have a vision in the desert. So now we start talking about opioid-free anesthesia, which is direct brain response monitoring with propofol and preemptive ketamine. We have a disclosure prepared by the attorneys of the Medtronic company. Thank you very much. And we have an additional disclaimer that says anything I say is really my opinion and they deny any responsibility. And I have my own disclosure. Why did I get involved with the brain monitor? Well, in 1997, from 92 to 97, propofol Diprivan was very, very expensive. And my plastic surgeons, cosmetic surgeons said, well, we love the anesthesia, but can't you find a way to do it cheaper? And so I started as an early technology adapter the day after Christmas. You may wonder, why does he remember such a date? In the West, Christmas is a big deal, December 25th. And it wasn't until a year later that I added the real-time signal of the EMG, which is the electromyogram of the frontalis muscle, which is every bit as real-time as the electrocardiogram of the cardiac muscle. And so this talk is based on my 20-year experience with the biz, and it's based entirely on the usefulness of the device. I have self-funded this 501c3 Goldilocks Foundation, and aside from Medtronic kindly making it possible for me to be here with you, everything I've done before today has been on my own expense. So not trying to monetize my work has led to great suspicion among many people. They said, well, what's his ulterior motive? What is he trying, what is he up to? Here I thought it was a noble thing to not try to make money from your work, but just to present it to make things better for the sake of making things better. So here is my ulterior motive. I want very much to be part of anesthesia history, just like Cushing's triad was part of neurosurgery and Virchow's triad for that. So that is my ulterior motive in case you want to know. Now here we are in 2019, pain and post-op nausea and vomiting are still the most common reason for outpatients to be admitted to the hospital, okay? So I want to start off with the punchline, my record. 26 years I've done opioid-free anesthesia for more than 6,000 office-based surgery patients. Not one single hospitalization for either pain or post-op nausea and vomiting. There have been no opiate addicts and no opioid overdoses. So I want you to keep calm and let that record set in. Why are pain and post-op nausea and vomiting still the most common reason for hospital admission? Albert Einstein has the answer. I say, giving opioids in anesthesia is insanity. You're doing the same things over and over again and somehow expecting a different outcome. He used the archaic word of results, but that was his day. So since 1993, I've stood in front of my colleagues 63 times as I'm standing here today. And I'm always faced with a feeling that people think, change? Who, me? Why would I do that? And for the first time in my life, I really understood how Christopher Columbus must have felt standing in front of Queen Isabella, telling him he had a better way to get to India, the shortcut, that he wasn't going to fall off the end of the earth, that the earth was actually round and not flat. Or when poor Dr. Semmelweis stood in front of the Austrian Medical Society to say, gosh, you know, I think it's really important to wash your hands, but this, of course, was 20 or 40 years before Louis Pasteur demonstrated the germ theory. They thought he was crazy. The problem we have in anesthesia is our beliefs imprison us. They impede our ability to achieve greater outcomes. These are our anesthesia beliefs. Surgery is painful, self-evident. Opioids are painkillers. You heard it from Dr. Zagul, right? And all surgery, therefore, at least requires the judicious use of opioids. Well, here we are in 1998 when I added the real-time signal. You see if I can get the This lower trace here, this is a picture from the cover of my book. I like to use it because it's a pretty decent picture. And now the solutions I found to post-op nausea and vomiting and post-op pain have become numerically reproducible. And that, my friends, is the basis of scientific medicine. Those of you who are expecting me to present a level 1 double-blind randomized controlled study will be sadly disappointed. But I hope that you will grasp the idea that a numerically reproducible approach is the essence of scientific practice. Now, I want to introduce my friend Homer. This is not the Homer of the Iliad and the Odyssey. You're going to see more of Homer on my Odyssey of opioid-free anesthesia, why and how. This is our old friend Jack Palance from the movie City Slickers, who said one thing. Well, my one thing for 26 years has been propofol ketamine for IV sedation for office-based elective cosmetic surgery. And the difference between a subspecialist, which I was in the early 80s as a cardiac fellow, I did all kinds of other cases except for pediatrics, and now is I only do one kind of case, elective cosmetic surgery. So the next question is, well, gosh, that's great, Dr. Friedberg. What about the rest of us? Most of us aren't giving anesthesia for cosmetic surgery. What do you have to offer us that makes any sense? And we have the common ground of the skin. Here you see my experience in cosmetic surgery, the medically indicated surgery. Anytime you violate the skin, it's absolutely worthwhile to follow my simple paradigm. A little history. In 1846, poor Dr. Semmelweis tried his best, and he demonstrated a decrease in maternal mortality when you washed your hands. The Austrian Medical Society had nothing of it. He wound up dying insanity and in poverty. Unbeknownst to him, on the other side of the Atlantic, Oliver Wendell Holmes, the father of the famous jurist, had the very same idea in 1846. They were on opposite sides of the Atlantic, and because there was no internet, they had no idea of each other. Now we flash forward to today. There is the World Wide Web. Dr. Zaglou and I met on LinkedIn. I have over 13,000 contacts on LinkedIn, and one of them was Dr. Moulier, who was kind enough to invite me in 2017, in December of all times, to lecture. But, you know, when he found out, he'd been doing it about 10 years, and when he found out I'd been doing 26 years, oh, we're having a meeting, you have to come. I said, but Chan, the meeting is 6 weeks away. You already have your speakers. No, never mind, you have to come. So come I did, and that talk is on YouTube, and it's been seen, as we're standing here today, over 2,000 times. Not too bad. So why do we want to give opioid-free anesthesia? Well, for me, it's pretty obvious. You don't want people throwing up, you don't want them in pain, and you don't want them hungover. In the office-based setting, we don't have a hospital bed to send a patient who takes a long time to recover. We don't have the ability to run a morphine PCA pump, okay? They have to wake up, they have to be not sick to this, they're going to be discharged straight to home, and there's no professional caregiver there. They don't need one. A lot of times people say to me, well, opioid-free anesthesia, Dr. Friedberg, aren't you afraid we're going to hurt our patients? And the answer is not a chance, not a chance. The paradox in anesthesia is we have this greater than 100-year tradition of giving opioids. The problem is they're not helpful. Patients still need opioids after surgery, which again, as Dr. Zaglou kindly illustrated very well, runs the risk of opioid addiction. So what we have to offer you is an objective, reproducible evidence of NMDA, N-methyl D-aspartate, receptor saturation. If you see no EMG spike, as we see here, if this doesn't happen with skin incision, and this is what happens, which is no response, you have objective, reproducible, numerical evidence that you've done your job. Much like in the old days that I was taught in my first 20 years, if there's no heart rate or blood pressure change with skin incision, everything is great. We're going to talk about that a little later. So basically what we're talking about here in this particular paper was the use of clonidine pre-medication. This was done in the time when I was desperately trying to minimize the cost of propofol. And once propofol became generic, it just didn't seem to be worth the side effects of the occasional hypotensive patient to continue. Didn't see any difference. Using clonidine, not using clonidine. Shocking. Okay. Let's try here. So basically, the game is when the red goes up, the white goes in. And you want to keep giving the white until you get the EMG back to the baseline. So it's kind of a My patients are all breathing spontaneously, but if you have a paralyzed patient, you're still going to see an EMG, and this is still a worthwhile thing to do. The 50 milligrams of ketamine only gives you about 10 to 20 minutes of dissociative effect. And during that time, you have the chance to introduce some subcutaneous lidocaine to prolong the brain's ability to receive information from the skin, okay? This is the most critical thing, as we were taught in the old days, of heart rate and blood pressure. You want to prolong this period of deception so the brain doesn't know the body's been invaded. So you use pre-incisional subcutaneous lidocaine with epinephrine, and before you close, you just splash some bupivacaine in the wound. Fundamentally, the brain cannot process information it doesn't receive. And so this is my perspective of what your 50 milligrams of ketamine does, blocking the signals. In 1993, I saw my first 50 cases. I should back up and say, for the first 15 years of my practice, never once did it cross my mind, why did patients need opioids after surgery? Well, it's obvious, isn't it? I mean, the surgeon has traumatized the body. Of course they need opioids. Then I saw 50 consecutive patients wake up not needing opioids, not being sick to their stomach, and not anything less than wide awake. It was what I call the OMG WTF moment. The reason patients were having pain after surgery is they were having pain during surgery. What did I think I was trained to do at Stanford? That's what we're supposed to do, right? That's our reason for existing. We're preventing pain during surgery. Guess what? The big lie. If you don't block those NMDA receptors before the incision, you're allowing your patients to have pain signals reach the brain. We can call it nociception if you like. It's a fancier word. Pain is simpler for me. Interestingly enough, in 2018, somebody came along and said, nociceptive activation of the spinal cord and brain persists even during deep general anesthesia. So if you've got the patient deep with massive amounts of narcotic or massive amounts, 1.3 plus MAC inhalational agent, nasty signals are still reaching that patient's brain. Fate intervened for me in 1991. I'll tell you a little bit later about how I got to see this guy, but I was working with two surgeons who wanted to start a surgery suite, and we wanted to hear this guy talk. He was talking about diazepam, sedation, preceding ketamine, and with that, you blocked hallucinations. Well, in December of 1991, in North America, we only had propofol for 2 years. And mostly everybody's giving it, in fact, everybody I could find at the time was giving it as a single bolus for induction before the institution of inhalational anesthesia, replacing our old friend pentothal. But it was very, very expensive, $12 to $15 US dollars for a 20 cc ampule. And historically, in the first 5 years, from 92 to 97, I was using an average of 3 ampules an hour. So people would say, you can't give that drug continuously. One of the many things they told me I couldn't do. So in March 26, 1992, I gave my first case for Eddie Damascus in Newport Beach. And yes, it's cost prohibitive. I couldn't find anywhere on the internet that would tell me that sleep doses of propofol were just as effective as sedation with diazepam in blocking hallucinations. That was my hypothesis, okay? That propofol would indeed block ketamine hallucinations. Well, there I am, I'm sailing off into the unknown, okay? If I was to ask for an IRB at that point, there was no requirement, but no institutional review board would have ever given me permission to start the work that has been so critically transformative of anesthesia. So I'm fearing failure. The first patient that wakes up hallucinating, it's the end of the story. I don't know what's going on. So those first 50 cases, literally, my knees are knocking. You know, don't know what's going on. My first peer-reviewed publication was, in fact, hypnotic doses of propofol block ketamine-induced hallucinations, 25 cases. And I was so focused on how much propofol I was using and making sure that nobody had hallucinations, it took me a while to absorb the fact that 50 consecutive patients woke up looking so profoundly different. They did not have the look of surgical trauma that we're all familiar with seeing our patients in recovery. So why no opioid rescue for these patients? It was a transformative moment, a sudden realization that patients had pain after surgery because we allowed them to have pain during surgery. I don't think you could be more fundamentally shaken to your foundations as an anesthesiologist to have this realization. And when I demonstrated at a SAMBA meeting my first 50 cases, people looked at me and said, "What, are you crazy? Ketamine in adults? Absolutely. You can't do that." Okay? But that was 1993. Now that ketamine is being used to treat PTSD, chronic pain, and severe depression, it's not the same reputation. Back in 1993, when people read the word ketamine on my poster, they backed away as if I was trying to give them HIV/AIDS. I mean, it was really very scary. The sad truth is that ketamine is still being taught that it causes hallucinations, hypertension, and tachycardia. Not everybody knows that ketamine was a second-generation PCP. In 1958, Park Davis investigated the phencyclidine class, and the first drug that they marketed was phencyclidine phosphate, known as its initials PCP. The drug was marketed as a trade name Serenel because the patients appeared very serene. Unfortunately, 80% of those patients were having horrific hallucinations, dysphorias, and flashbacks. So the drug quickly left the market, okay? 13 years later, you would think Park Davis would have learned something from their initial marketing experience. No. Again, ketamine is a complete and total intravenous anesthetic. You need no other drugs. Well, the sad truth is that sometimes people don't want to hear the truth because they don't want their illusions destroyed. In spring of 2009, the Anesthesia Patient Safety Foundation published one of my letters that said, in a specified context, ketamine is non-adrenergic and it produces opioid-free preemptive analgesia. People say, well, Dr. Friedberg, there's other devices on the market. There's Entropy, there's Sedline. So Biz happened to be the first one on the market. This is not a binary choice. I'm not here to sell you any particular manufacturer's device. Okay? It happens that Biz is the most validated device on the market. It's been published in more than 3,500 studies, and I don't think I've yet to see a paper that says this device is superior to the Biz. There's at least one or two that say equivalent, but with a 20-year experience, it's just like most people don't want to change how they give anesthesia. It's very hard for me to get excited about somebody else's brain monitor. Propofol ketamine, as I describe it, is not a mixture. I don't know how many people here have ever seen a martini. I understand that alcohol is pretty much haram, but that's okay. The metaphor I'd like you to take home is that the dose of ketamine, that 50 milligrams of ketamine, is the perfect olive to the propofol martini. Now, many, many people around the world mix the two drugs together. That's not what I do. The picture here is showing you what would happen if you blenderized the olive into the martini. The trouble is you can't tell the effect of either drug when they're mixed together, and that's part of the problem. So the story in this case is hypnosis first and then dissociation, and people say, but Dr. Friedberg, every other drug we give is based on body weight. Well, when you see 110 kilogram males respond identically to 55 kilogram females, you have to ask yourself, how can it be body weight based? And so the 50 milligrams is a simplified thing. Now, there is controversy about ketamine and the use of Biz. Dr. Sengupta published in 2011 that with what his perception was a stable propofol level, that even a 0.5 milligram per kilogram of ketamine causes an elevation in Biz. Unfortunately, he was unaware, where did we go? He was unaware of my 1999 paper that said, actually, when you measure the level of propofol and create that stable level, a 50 milligram dose of ketamine produces no change in Biz. As my friend from South Africa said, well, what about internal pain fibers? My answer is that they're exponentially fewer there, but the skin is the most critical for pain outcomes. Still, the joy of preparing this lecture, some of my other opioid-free friends around the country told me about these two papers. This 2011 paper where they used pre-incisional IV or sub-Q ketamine and showed a remarkable decrease in post-op pain. Another one with open hysterectomy, again, they're giving 100 milligrams of pre-incisional ketamine and showed decreased post-operative pain. My conclusion is that the population number of NMD receptors is very small, does not appear to change with body weight or age. My endpoint in the first 5 years before brain monitoring was immobility, to local anesthetic injection, and my N is 1,264 patients. Okay? It's a large anecdotal number, but it's reproducible. When I was a resident at Stanford in the mid-'70s, they described ketamine as the mineralizing drug. And I said, what do you mean mineralizing? Yeah, when you give it, they lay there like a stone. I guess that was Stanford anesthesia humor. We're going to talk a little bit about how you induce. It typically takes 2 to 3 minutes, and I tried my best with Google Translate to translate the tortoise and the hare. I'm not sure that that's good, but that's as good as I could get with Google Translate. Essentially, what you're doing is very analogous to what you do when you try to get a lidocaine level to treat arrhythmias. You don't start off with a big bolus, you start off gradually and increase to the effect that you're looking. Now, here's the problem with dosing on the bell curve. Even though we pay a great deal of lip service to individual patient variation, the reality is everybody gets an average dose, and the people on either end of the bell curve, well, we have to pick up the pieces, and that's the best we can do. And that was okay before 1996, totally acceptable. What choice did we have? We have a choice now, okay? We can directly measure and deal with 100% of all patients. Here's my perception. This is an elephantine question. How do you dose direct monitoring? Do you use body weight? Do you use heart rate and blood pressure changes? Pharmacokinetics, pharmacodynamics, body mass index, targeted concentration index, TCI? It's like five-blind anesthesiologists trying to define the right dose. Well, the problem is patients fear but rarely ask, doctor, after I'm asleep, how do you know how much to give me? And my answer is direct cortical response monitoring puts you in control of your anesthesia dose with the number from your forehead. In 18 of my 20 years of using the brain monitor, it took me to find the magic word the patients want to hear most: control. Control is what they fear most when they go unconscious. Now, I want you to set your smartphones timers, and I want you to think about this the next time you go back to the operating room and compare the time it takes me to achieve a stable level of propofol that will block ketamine hallucinations. Compare this to the time it takes you to pre-oxygenate, bolus induce, paralyze the patient, intubate, and confirm tubal placement. This is a clip that has, between the two talks, this clip has been seen over 160,000 times on the internet. Blows my mind. I check those numbers every day, and it's just amazing to me. Okay, every time I touch
the red area, EMG,
every time I touch the pump,
before the yellow,
patient's receiving 50 micrograms per kilogram.
Bismon.
So who can put a patient to sleep? Well, it makes it very hard to make somebody stop breathing.
Especially when I'm standing.
Come on, new person, right? Okay, because I'm going right now. I feel it.
Hopefully
Relax.
it feels pleasant.
It feels pleasant. This is like my ideal way to die, but I mean...
Well, we tend not to do
old,
that.
and I'm like 106, you know?
Yeah.
I want my dog by my side, though.
The short answer is it's 2 minutes and 35 seconds, but that compares very favorably to what we do normally for elective cases.
Alright, here we go.
So this young lady is a nice young lady.
Will I be twitching?
No, no twitching. But it
I
just,
might be gassy because I didn't eat, but
yeah, that's okay. We don't charge extra for gassiness.
I'm feeling a little drunk.
But it's pleasant though, isn't it?
It's a drunk feeling.
Yeah. So
I might say, I'm sorry, staff, but I might say shit that I don't know.
you would say.
Just don't worry, you know, I haven't had food since 10, so.
So we already dropped into the 80s.
Fortunately, this little video doesn't have audio in it. It's just the video, so
Please don't mind my dry mouth.
it's okay.
This is a nice feeling.
Isn't that nice? Now you know why everybody likes Dr. Friedberg.
That's the Dynamat. The
And when I
automatic
get
blood
home,
pressure
can I
device.
eat?
Yes,
How immediate?
immediately.
Okay, but I made some good curry.
And now we're into the 70s,
If I
the
wake
high
up
70s, and we're approaching
anesthesia, it is.
75.
I eat, right?
Yep.
How many
Okay.
One
How
Italian
many,
anesthesiologist who visited me kept marveling at how slowly I did things. In fact, she called me Dottore slowly. How can you do so slowly?
how many,
Watch.
put your arm right here. I spent,
Slowly, slowly, but you don't see any instrumentation of the airway, and yet you hear no change in the pulse oximetry. Sounds pretty
I got both.
static.
I got her and I got the Viz in frame.
Super, perfect. That's great. You can stop now.
I started my career as an adrenaline junkie giving cyclopropane anesthesia in 1972 in Copenhagen. But as I got older, the thrill of adrenaline excitement kind of got old, and I really liked boredom myself. At any rate, the clip that Dr. Zagul showed of me on the doctor's show was when I said there's a 60-fold variation. Actually, since then, another 6 years or 7 years has gone by, and I've actually seen a 100-fold variation. 3 patients, 3 out of 4,000, took less than 10% of my average dose. Most patients are titrated between 25 to 50 mics per kilo per minute to stay in the range between 60 and 75. That's the sweet spot for me. Here is an incredibly sensitive patient right after induction. Hopefully we can get this thing to run. Maybe not. Okay, it's not going to run. At any rate, so at 2 mics per kilo per minute, if I told you that this patient was otherwise healthy and unremarkable, 60 kilograms, 61 years later, you'd say to me, it's not possible, Dr. Friedberg. I don't know if the second one's going to run either, but we'll see. Oh, there we go. Wasn't aggressive enough. Sorry about that. But this just makes you say, how can this possibly be? How can somebody who's ordinarily healthy be satisfactorily sedated at 2 mics per kilo per minute? Well, it's very possible if you go slowly on the induction and let the patient tell you how much they need. Measuring is better than guessing. And there you see, 2 mics per kilo per minute. She's 60 kilograms. It's just unbelievable. And when we turned off the propofol, she woke right up. I want to talk a little bit about the airway, because that's kind of a big deal. The incremental induction outcomes are that you keep the airway and spontaneous ventilation. The muscle tone of the genia glossus, orbicularis, the kissing muscle, the masseter and temporalis, the chewing muscles, tends to have the muscle tone maintained. Many a times I've induced somebody who had a thick neck, who was obese, and I thought, there's no way I'm going to get by with this case that I don't have to put an airway in. And amazingly enough, when you go slow and titrate, you often are very, very surprised. So the bolus induction is the enemy of a patent airway and spontaneous ventilation. I'm not too big on the can ventilate, can intubate scenario. And that's why spontaneous ventilation is you first do no harm. In 2007, Dr. Drummond published that you avoid over-medication because you have a feedback loop with spontaneous ventilation, and you avoid ventilator trauma. Well, this is a trade journal article I wrote for Outpatient Surgery magazine, and surprised to my no end of surprises that the Karolinska Institute anesthesia people put it on their website. Minimally invasive anesthesia for minimally invasive surgery. As you've seen from the clips, I'm a shameless self-promoter, and I was perfectly happy to steal the term minimally invasive from the surgeons. So what happens is you decrease post-operative airway incidence, especially for sleep apnea patient. The problem is not every patient who has sleep apnea comes with a sign, danger, I'm a sleep apnea patient. They're undiagnosed. And you find out much to your regret by using opioids that you set the scenario for an unpleasant outcome. Okay. So I'm not using neuromuscular blocking agents or reversal agents, and we never have a problem with inadequate reversal. So using non-opioid analgesic modes for pain management is associated with decreased complications and resource utilization. And this was specifically targeted in an article this year in obstructive sleep apnea patients having elective joint arthroplasty. So the basic concept of airway management is if it isn't broken, you don't have to fix it. There's no shame in having a patient breathe spontaneously. And like I said before, you don't have to have the scenario ever involved. You know, in the office-based setting, we don't have video laryngoscopy. We don't have a lot of support. In fact, we have very little support. So you're kind of out there by yourself, and the least you trespass upon the patient, the less mischief you create for yourself. So here's Airway Management 101. This is the rightedectomy or facelift position. That's chin up and head turned to the side. So that gives you 2 vectors of force on the genioglossus muscle. About a third of my patients are like that. Now I want to tell you that we have culturally similar patients. From the days of Al-Andalus, the Spanish conquistadors came to Mexico, and many Mexicans inhabit Southern California. So we have a lot of very high-strung people in both our populations. And one of the things they never told me from the aspect days, it actually hurts to have a sensor put on your forehead. And so for 2 years, I'm listening to patients say, ouch, and get jumpy and wonder what's going on. And finally, I went to a meeting, they put one on my forehead. I said, oh, okay. Well, what happens is it gives you some clue to the patient's pain tolerance. I have every patient, I show them the sensor, I let them touch it, and to assure them that I cannot puncture skin or create a scar on their face. Very important in the cosmetic practice. And I explain to them it's a small price to pay to be in control of your own anesthesia dose. One of the other wrinkles that I evolved in the high-strung population, especially for the patient who is lying still perfectly during the surgery but wakes up bitterly complaining of pain, say, well, is this pain from the surgery or is this pain from your cultural disposition? There is a differential. So giving acetaminophen plus diphenhydramine, either PO or IV, is a way to go to manage the situation. Paracetamol or Tylenol PM, we call it the big blue pain pill. If patients ask, we tell them, but I find it often destroys the therapeutic efficacy if you tell them. Essentially what you wind up with is analgesia and tranquility. Again, I used Google Translate for this. I'm not sure that that's really the case, so if it's bad translation, blame Google. At any rate, sometimes the surgeon is in the way of that montage. And so what I discovered is by moving it up here, I get perfectly satisfactory numbers, and a facelift is not really a sterile procedure unless they're going to put some kind of an implant. You want to dab, not scrub the sensor, because if you scrub the sensor, you'll dissolve the adhesive, and then you've lost the deal. This is Nick Issei. He is one of the 3 people credited with pioneering the endoscopic brow lift. He and I worked together for 5 years until I had to take time off to write the textbook in 2004. We did every one of his facelifts, every one of his brow lifts, every one of his cases with the bispectral index monitor. So now we move to Airway Management 2.0. If you can't keep the tongue off the back of the throat with the facelift position, put an IV bag, not heated, an IV bag under the shoulders and not under the neck. This increases the force of extension on the genioglossus. Another third of my patients are managed perfectly fine with that. So you see that more than 50% of opioid-free anesthesia patients don't require an artificial airway for support. And Mies van der Rohe was the father of Bauhaus architecture, and he said less is more. You say, well, what's the big deal about putting an airway in, Dr. Friedberg? So the cosmetic surgery patient will complain of anything. If they have a sore throat from a tube in the back of their throat, from the airways, or an IV stick, they will complain bitterly to the surgeon. So that's what I do. So we're moving along, Airway Management 3.0. If I still can't keep the tongue off the back of the throat, I prefer the nasopharyngeal route. Patients seem to cough less. I discovered this in my 5 years doing ambulatory surgery in a surgery center, that smokers as well as non-smokers tend to cough a whole lot less with a nasopharyngeal tube. Still, if you can't keep the airway open with that, I go to a laryngeal mask airway, and the only case that I routinely use this for is an open rhinoplasty or whatever, closed rhinoplasty. The Flexi LMA allows you to tape the tube to the chin, and it preserves the surgeon's sight line to the nose, about 5 to 10%. So the airway management outcome, no endotracheal anesthetic, endotracheal tube is required for the last 26 years, and my N is greater than 6,000. Moving now to the other interest of us, pain and post-op nausea and vomiting. What's the big deal about pain, you say? Well, that was the beauty of anesthesia. In the old days, you know, it was a great leveler between royalty and commoner, was the agony of surgery. So keeping patients from having pain was really our primary goal. And the goal of non-opioid or opioid-free anesthesia is NMDA receptor saturation. And saturation is different from block. Block implies a variable percentage of saturation. Saturation means 98 to 99%. There is no signal reaching the cortex. The midbrain is the final pathway. I have some inflammatory comments for us. Surgery, we know, itself is inflammatory. Sevoflurane and the other inhalational anesthetics also raise inflammatory markers, but neither propofol or ketamine raise inflammatory markers. The inconvenient truth is that patients are much more concerned about throwing up after anesthesia than pain. And if you think about why that could be, is patients have signed up for surgery. They have an expectation that they're going to have some degree of pain. But the conscious consent that they sign for surgery does not mean that the unconscious patient happily receives the news that the body's been invaded. Post-operative nausea and vomiting. Well, what's the big deal? We give antiemetics, right? So how important really is PONV? It turns out that Alex Macario published in 1999, it was the #1 patient concern. Okay? This is what happens when you give anesthesia with opioids and antiemetics. I could have used one picture, but I wanted to drive the point home that nobody dies from post-op nausea and vomiting. You only wish you were dead. Okay? Christian Apfel said, as long as emetogenic agents are part of the anesthetic regimen, antiemetic use is of limited utility. The concept of limited utility is academic speak for kind of a waste of time. And you might say, well, who's Christian Apfel? He's one of those exceptionally rare anesthesiologists who succeeded in publishing his work on the 4 main factors for post-op nausea and vomiting in the very prestigious, very stuffy academic internal medicine journal, the New England Journal of Medicine. Why do you want to abstain from emetic drugs? The same reason you don't want to throw a match in the gasoline. And that's the problem. One of my early converts is a guy named Chris Pollock in Hull, England. And he said very simply, well, if you want patients to stop throwing up, stop giving them drugs that make them sick to their stomachs. It seems kind of self-evident, I would think. So as Pogo said, we have met the enemy, he is us. So I have this great PONV solution, but who listens to an LMD? I don't know if they use that expression here, but LMD stands for local medical doc. It is the most scathing comment of the academicians. It implies this is this bumpkin who doesn't read the literature, practices outdated medicine, doesn't have any idea what he's talking about. He has no academic credentials or standing in the community. Who is this guy? I thought that speaking and publishing would create a force for change. It does, about this much. And I'm very fortunate to have all of you here, and I want you to know that even though I have a boutique practice, I treasure each and every one of you as much as I treasure each and every one of my single patients, because you have the force for change to make. My primary publications are listed here, but the problem is, who in anesthesia? Well, we've got snuck one in there, Journal of Clinical Anesthesia. That was the Biz Monitor. And I will remind you that at least 50% of all publications are never cited by a later author. So if only one later author cites Dr. Friedberg, that puts me ahead of half the literature. Half the literature. Why? Because publish or perish is what drives the need for publication. It may be statistically significant, but it's most likely clinically irrelevant. My subsequent references include more than 175 papers and more than 50 anesthesia textbooks, including the last 2 editions of Miller's Anesthesia. Pretty cool. In 1846, Surgeon John Warren said, "Gentlemen, this is no humbug," and I would say, amen. I have still the lowest published postoperative nausea and vomiting rate of 0.6%, cited by Christian Apfel, and he compared me to Paul White, 7%. I said, well, anytime you get compared to the living legend Paul White, tenfold better, that's got to be pretty cool. And this paper was published in an Apfel-defined high-risk group. No opioids, no antiemetics. Here we go. Non-smoking female patient with previous history of motion sickness or post-op nausea and vomiting, having what he called emetogenic surgery, like cosmetic. But the reality is, how does Miller really prioritize patients' #1 concern when the PONV chapters are in the back of the bus? okay? The 2010 is chapter 86 out of 89. The 2015 is chapter 97 of 117. So I think he's kind of clowning around about this whole thing. And why are we so delinquent about patients' number one post-operative concern, post-op nausea and vomiting? Well, as Kermit the Frog says, not my problem. It's somebody else. We take them to recovery room, we dump them, and we're either back to the operating room to do the next case or out to the golf or tennis, okay? And then we wonder, why don't our colleagues respect us and love us? Well, we create the problem and they have to deal with it. So minimizing opioids is like being a little bit pregnant. You either do opioid-free anesthesia or you don't. Back to the subject of direct cortical response monitoring, there is BIS, entropy, SEDline, take your choice. But the point here is please find a device that you like and measure what you're medicating. After all, would you give a blood pressure medicine and not measure the blood pressure response? You can't be serious, right? This is John McEnroe, for those of you who don't recognize the temperamental one. So why would you give a brain medication and not measure the brain response? John says you really can't be serious. So in 1996, Aspect Medical System got FDA approval for the BIS monitor as a direct cortical response measurement. The twin tragedies of Aspect's monitor is they decided in 1998 to pander to the general public about preventing awareness under anesthesia. The other problem is that the device had limited utility. So the sins of the fathers, as it turns out, Aspect Medical, were inherited by Covidien and subsequently again by Medtronic. And so I say, what is science? Well, I first heard this famous quote in 1966, my freshman chemistry. Made a big impression. William Thompson said, when you can measure what you're speaking about and express it in numbers, you know something about it. When you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. It may be the beginning of knowledge, but you have scarcely in your mind advanced to science. So it's intuitively obvious that the brain is a target organ, and to directly measure it means that you have a reproducible numerical response. All right. So as a glacial change is glacial, and in the fall of 2007, again, the Anesthesia Patient Safety Foundation published my letter that, gee, the brain is the target organ of anesthesia. I was staggered. Really, guys? You're just acknowledging this now? At any rate, here's my perception of what happens when you violate the skin either by incision, trocar puncture, or multiple local anesthetic, and you don't use preemptive ketamine. The brain goes boom. The brain says danger, danger, invasion, invasion, and whatever it is that happens when the brain receives information is not good. See, the anesthetized brain can't tell the difference, can't differentiate between a mugger's knife and a surgeon's scalpel. The same effect happens. We see here the headless chicken, who shows you that you don't need a brain to generate movement. All movement is not equal. There is subcortical as well as cortical origin, and the differentiation is critical to knowing how to manage the patient. After a spinal anesthetic, we say, well, input to the brain stops here. But with the dissociative ketamine effect, we move that, okay, overzealous. Here we go. Well, I guess I'm going the wrong direction. We move that up to the midbrain. So how many people here thinks it's a reasonable idea to drive your car just looking in the rearview mirror? Well, that is the problem using the bispectral index monitor as its factory configuration. So here I am in 1997, starting off. I'm the first anesthesiologist in Orange County, California, to be doing this. And remember, classic clinical signs of heart rate and blood pressure were absent in most cases where there was awareness under anesthesia. So if your only concern is the brainstem, changes in heart rate and blood pressure are great. But hopefully I've raised your level of consciousness to say, maybe it's really time to know what's going on above the tentorium. Heart rate and blood pressure changes are notoriously unreliable cortical guides. They reflect a nice thing with the brainstem, and here's what set me off. There we go. This was a landmark paper. This was Lee and colleagues, and The editors of Anesthesiology did not deem this article worthy of a special interest article. I was flabbergasted, absolutely flabbergasted, because this is from the homepage of my foundation. Of the 40 million people in America who receive anesthesia, fully 16 million, 40%, wake up with some degree of brain fog. Call it POCD, delirium, and if you're really unlucky, you're one of those people in the clip that said, well, gosh, one person a day dies. So the reason I'm nodding my head is I'm on live TV, and this surgeon, this plastic surgeon, is asking me this incredibly stupid question, and I'm trying to think, what can I possibly say while I'm on live TV that will make some kind of sense? So is awareness and recall the biggest problem we have in anesthesia? Hardly. It's 0.1%. The rest of people are being over-medicated, and it's especially bad if you are over 50. So this was my impetus to create my nonprofit foundation and the book that was written for the general public with the hope of starting the same force for change you got fathers in the delivery room. I'll show you later that it's just not going to happen from the anesthesia community. People always say, well, Dr. Friedberg, if you believe in something so passionately, why don't you put your money where your mouth is? Well, up to 2010, getting the 501c3 paperwork done for the IRS, the Internal Revenue Service, as well as creating the book. It has a Library of Congress number. It's on Amazon. And I've given over 7,000 hard copies away, including the 64 today. So that's what a charitable foundation does. In 2000, I published a statistically significant 30% reduction of using propofol with real-time EMG BIS monitoring. Now we have numbers and we have science. I'm not sure that over-medication is the cause of all post-operative brain fog, but it doesn't pass common sense to say in older people, it's still okay to give 30% more drugs. I believe once we have brain monitoring as a standard of care, at least we've eliminated that element. Now, what happens to the body with the inflammatory response of the surgery alone, we really are unable to tease out, but over-medication can't be a good thing. And here's why the change is not going to happen from the Anesthesia Society. 4 of the 9 major corporate sponsors are drug companies. So we have what's called a conflict of interest. The fox is guarding the hen house, and again, I did my best with Google Translate to give you an Arabic thing. I don't know if that's a thing in the Arabic world, but here we have the best available over-medication avoidance technology versus ASA being in bed with Big Pharma's support. So why do you think there's so few opioid-free anesthesia lectures or articles? Dr. Moulier has submitted multiple times to the ASA to present opioid-free anesthesia. I've also presented. Stop and think for a second. What is the potential financial impact if we stop giving opioids, stop giving antiemetics, and use 30% less propofol? That's a big hit. So when will patients' best interest become number one? In my world, it's mañana. Here, perhaps it's bukra, perhaps even inshallah. Okay. Now to the essence of the EMG story. EMG activity, as I showed you those spikes, is a warning that the patient may be ready to wake up. Many times I've heard from people that the patient was going along just great at 40, and then all of a sudden, I said, well, were you using a real-time signal? No, we were just following the biz. And again, I say, well, do you drive your car just looking in the rearview mirror? Wouldn't you prefer to look through the windshield to see where you're going? And people say, well, what about Botox in the cosmetic patient, or what about patients who have muscle relaxants? My friends who still do cardiac surgery, I asked them that question. They said, no, the spikes still persist. So I'll remind you, without input, you cannot process what's going on. Opioid-free preemptive analgesia. No brain, no pain, says Homer. No input, no windup. Again, no input, no nociception. My place for the ideal regional block is right there below the tentorium. You block afferent signals from reaching the brain, patients wake up, they look like they haven't had surgery, and they don't need opioid rescue immediately. Here are the numbers for the bispectral index. Awake is 98 to 100. Moderate to deep sedation, where I titrate patients, 60 to 78. I will tell you that in 4,000 patients in 1998, no awareness or recall has happened at this level without midazolam pre-medication. I did, in that 1999 paper, published the 1,000 patients that I collected data on 0, 2, and 4 milligrams midazolam. Couldn't find any difference in propofol requirements. Oxorn, a couple of months later, published an article that says, yeah, it doesn't help at all. So using a SED-line or bispectral index monitor, you can directly monitor the organ you're medicating. You have reproducible numbers, and now we can all talk about the same thing, at least with one device or another. And with the EMG, you know that the patient's ready to wake up. So my postulate was that arousal precedes nociception. Again, if it doesn't reach the cortex can't do anything with that information. The validation is for that 20-year period and 4,000 patients, slightly more, no post-op opioids, no hospital for admissions for pain management, and none for post-op nausea and vomiting, no opioid addicts, and no opioid overdose deaths. Here's the sad story about why is BIS not used more often, aside from the fact that Aspect Medical really upset the anesthesia establishment, and they will never forget that, okay? The way the device was rolled out originally, that's the only information you have, which is just like looking in your rearview mirror. Here with the EMG activity, you're looking through the windshield. You know what's going to happen before, and you have the drop on the patient. So the classical abdominoplasty, I was just talking to somebody before, is that this is a major invasive surgical procedure. It can only be done with profound muscle relaxation, spinal epidural, general endotracheal with paralysis. And what I'm showing you below is that we're not putting in a retractor to hold the rectus muscle apart to get into the belly. We're moving the rectus muscle just a little bit together, a couple of inches. So I'm going to show you this clip, and this is before the days of end-tidal CO2 being a standard of care. Let's see if we can make it happen. You can see here, this is the sheath, not the muscle itself, just the sheath.
This afternoon.
Here are the pulse ox. It's going to go down. You're going to lift your chin, come back up. Room air, spontaneous ventilation. In and off the space 7.
You like that camera?
I love it.
Is it an HD one?
Yep. See the spikes that I'm talking about? This is room air. You see I shove the turn her head to the side, lift her chin, listen. That's how little trespass it took to bring her set back up. So truly minimally invasive. Again, measuring, titrating, going slowly. Okay, and here she is less than 5 minutes after we discontinued the propofol. Okay, Lily, what did you think about the experience? Was it pretty good?
Yes.
Did you remember anything? You've been asleep for 4 hours.
No.
Don't remember a thing. No bad dreams.
No.
Wonderful. So that was really a good experience then, huh?
Yes.
You like Dr. Lin, don't you?
Yes.
He's the best. And
Yes.
Anais held your hand, and I held your other hand, and you had a good snooze.
Cool.
And no dreams.
No.
Fantastic. All right, well, speedy recovery. So I've had many anesthesiologists, some internationally, many from my own country, come to watch, and they always ask the same question at the end. They say, what was the trick, Dr. Friedberg? What did you give that we didn't see? And my answer is always, your brain will not accept what you just saw because it flies in the face of what you were taught and what I was taught about what are the requirements for abdominoplasty. So the shorthand for opioid-free anesthesia is a little glycopyrrolate, incrementally titrate the propofol to below 75 with baseline EMG, very important. Give the nifty 50 of ketamine. I say nifty 50 because 50 is the dose and nifty is the incredibly marvelous outcome. You saw in this woman, it was a very typical. Lidocaine sub-Q. and bupivacaine splashed in the wound. You don't have to inject it. It binds very quickly to tissue, and if you inject, it's one more reason to cause bleeding. So as the fellow I was working with said, teaching opioid-free anesthesia is simple. Teaching cooperation is not. And I will admit to you, there are many surgeons who are simply unteachable, but you can still give pre-incisional ketamine. So the surgeon's golden rule is, number one, defining when is the patient asleep and amnestic? Well, between 60 and 75 with baseline EMG, okay? The biggie here, and this goes back to my days of having my hair transplant many, many years ago, is that vasoconstriction does not equal adequate analgesia. So I'm working with an old-time plastic surgeon, and he's numbed me up, and I can feel both the chronotropic and inotropic effects of the epinephrine. I'm fine. And he's puncturing my periosteum many times. So the first time I said, George, ouch, it hurts. I have nothing, no oral sedation, nothing, just wide awake. He says, no, you're just feeling pressure. Okay, the second time I said, George, it hurts, would you put some more local in? No, you're just feeling pressure. The third time I said, George, if you don't put some more local in, I'm going to stand up, I'm going to hit you. Okay. So it got me to thinking, aside from the fact he was your classic arrogant plastic surgeon, why is he so resistant when a wide awake patient is saying, it hurts? And it finally occurred to me after many months of thinking, in his mind, he sees the vasoconstrictive effect. He knows the epinephrine and lidocaine are in the same syringe, and historically, that's what he was taught when he had no anesthesia availability, that as long as you see vasoconstriction, patient's fine. If they complain, it's just because they're feeling pressure. Okay, all the vasoconstriction is telling you is that you have great epinephrine effect. Key thing here is the surgeon's golden rule number 3. If you see patient movement and no EMG, that movement cannot originate from supratentorial sources. That's subtentorial spinal activity. So all that means is you just have to put a little more local right in the immediate area, and 98% of the movement stops. Movement plus EMG activity means more local and more propofol. You don't want this to be the environment in the operating room. The famous beer commercial was taste great, less filling, and the anesthesia and surgeon are always too light, needs more local. So really this is not good. Using the brain monitor makes it possible to do cases with less trespass. So keeping it simple, we can do it, Homer says. Responding to EMG spikes becomes a virtual video game. It increases interest. All of us approach a patient preoperatively and we have our own assessment. Is this going to be a difficult case to sedate, or is this guy going to be a lightweight or heavyweight? What are we going to do? What you find by measuring is that most of our intuitive guesses were no more than guesses, and you're as often wrong as you're right. You say, well, maybe Dr. Friedberg was right. Measuring was better than guessing. So again, I remind you, the pre-closure of bupivacaine splash not injected prolongs the ketamine and the lidocaine deception. Nociception without the NMDA saturation is like a punch in the nose. It comes on real fast and real hard. When you have the propofol protecting the brain from the side effects of the ketamine, you've saturated your NMDA receptors, given the lidocaine, the bupivacaine. It becomes an incremental knowledge that the surgery has happened. And yes, you do have to deal with the pain consequences, but they're farther out and often are very easily taken care of with round-the-clock acetaminophen 1,000 milligrams. We come to the subject of adjuvants, or how can we make something so simple more complex? Okay, I admit I was using clonidine, trying to mitigate the cost of the propofol. I thought I was doing good. When propofol became generic, I stopped using it, saw no difference. When Vioxx was on the market, gosh, that's going to be a great thing, NSAIDs and all that good stuff. And I thought, again, wow, this is much better. When it went off the market, I no longer had it, didn't see any difference. Tylenol, acetaminophen, I tried that. Okay, that was nice, but the surgeons weren't going to sit still for a $10 dose of IV acetaminophen when the patients were perfectly capable of taking it oral. No big deal. I tried magnesium sulfate, 2 grams IV early. Mets. What I find useful is 10 milligrams of dexamethasone with induction. I've never used continuous lidocaine, dexmedetomidine. These are the bailiwick of Jan Mulier, and I give him credit. But I say, again, we're making something so simple more complex than it needs to be. And in an office-based setting, when you have very little backup, why make it more difficult? Why embellish the thing? Exparel, I think, has some use. People are using it. They seem to be doing better, but I seem to be doing just fine without it. Okay, so there I am. It's 2001, Lakeshore Hospital in suburban Montreal. I'm 9 years into my paradigm of propofol ketamine, 5 with the brain monitor, 4 without it. I give a nice talk. We hand out papers. We have Q&A. And I get a call 6 weeks later and say, you know, Barry, it's a really good idea, but not if you give the ketamine first. So I realized that it's not good enough to tell people how to do something. It's critical to tell you what not to do. I forget who it was. It was Eleanor Roosevelt. Try to learn from the mistakes of others because you can't live long enough to make them all yourself. Number 1, don't give the ketamine before the propofol is below 75. I have the carat tone the wrong way. And don't exceed more than a total of 200 milligrams of ketamine, because patients will have prolonged emergence and nobody will be happy. Number 3, don't bolus the propofol to knock the patient out quickly, because you set the stage for airway mischief, which you don't really need, and the patient doesn't need either. Another biggie is don't expect to hear crowing with laryngospasm. I will tell you that ketamine does sensitize the upper airway. That's why we give the glycopyrrolate up front, because any secretions that find their way onto the vocal cords will cause that. It's a total closure. There's no crowing. And the prodrome, the only thing you'll hear is a cough or a sneeze. That's the time to pay attention. So ketamine laryngospasm is pretty rare. I think I did my first 100 cases before I actually saw it. I really didn't know what I was dealing with because there was no crowing. When I put a bag and mask on, it was like trying to ventilate the wall. I mean, I just couldn't do anything. So it may be more common at the lighter levels of propofol, but I like minimally invasive. If you go 40 to 60, you may see less. I have no documentation to share with you on that. So, number 5, don't expect to hear crowing with laryngospasm. Cough or sneeze is your only prodrome. Don't try to treat it with the traditional approaches of jaw thrust and positive pressure ventilation. Doesn't work, it's not useful. And don't try to treat an elective cosmetic case, laryngospasm, with succinylcholine, because now you've increased the malignant hyperthermia risk, however small it is. Again, when you're in an office-based setting out in the periphery, you don't have a lot of extra hands to help get the dantrolene going and whatever. So again, if you don't break something, you don't have to fix it. The treatment that I recommend is IV lidocaine, 2 milligrams per kilogram, or in the States, I say 1 milligram per pound. And last of all, don't tracheostomize the patient for laryngospasm. Give them a little IV lidocaine. Simplified opioid-free anesthesia, you put the patient to sleep, hypnosis first, then dissociation with the ketamine, slip the local anesthesia in. Dose and timing are the critical issues, okay? If you want to be successful with opioid-free anesthesia, you have to saturate those NMDA receptors, and 50 milligrams is the way to go. Timing is everything. 2 to 5 minutes. You need a couple of circ times to saturate those NMDA receptors. So I remind you, the most critical surgery stimulus is the violation of the boundary between the outside world of danger and the inner protected world of self. Without preemptive ketamine, you're closing the barn door after the horses left. And again, I tried Google Translate to give you the Arabic, and I apologize if it's a bad translation. But what happens without the preemptive ketamine is you increase the probability of post-operative pain, the need for opioid rescue, and again, the risk of addiction. So you say, well, is this technique perfect? I say no. It's just better than all the other alternatives. So we can skip this slide because you've already seen it. Again, I remind you of my ulterior motive is to earn a place in anesthesia history by helping you do better for your patients, simply because it's just the right thing to do. Measure the brain, preempt the pain, and medic drugs abstain. Now, I'll tell you, when you challenge conventional wisdom, you have to prepare for the storm. But as the years have gone by, the personal suffering that I've endured, secondary to ignorance-based criticism by the so-called expert, is nothing in comparison to the amount of suffering this paradigm has helped patients around the globe. So I will say, as the Grateful Dead say, this has been a long, strange trip, or as my wife sometimes says, it's creeping credibility. The fact that we've gotten an audience this big is very heartwarming because I know I've only got so many years left on this earth. I hope there'll be a long time, but the idea that I can come and help others is really what motivates me. So the question is, how do you want to be perceived? Do you want to be the hero to your patients and your surgeons, or do you want to be the scapegoat? Yeah, it's anesthesia's fault. And let's see if we can get this one to play. When you've had enough sitar music, raise your hand and we'll stop. This is what happens when you grow up in the 60s, the Beatles. By the way, is the sunset behind Catalina Island as I see from my house. Southern California. Okay, it's enough, okay. Thank you so much, Shukra. I hope you've enjoyed my presentation, and I'm happy to field questions. Please feel the only foolish question is the one you didn't ask.
I think you have a lot of questions. Who want to start?
Sir, my question is that we have discussed the opioid-free anesthesia regarding the intraoperative part, but we didn't discuss in detail how do you manage the post-operative period without opioids. What actually you do, how you manage that period.
How do you manage the post-operative support?
Yeah.
Well, fundamentally, again, you don't have to fix something that isn't broken. When the patient wakes up and they're not in pain, it takes you a long time to absorb the fact, probably 10 or 20 cases before you say, Dr. Friedberg was right. I never saw patients come out of surgery like this. How can this possibly be? But after 10 to 20 cases, you can understand why a guy who's been giving anesthesia for 40 years remains excited about what he's doing and what he's trying to help people achieve. I don't know if that's a satisfactory answer, but that's, you don't have to fix, you don't have to treat pain that hasn't happened because, again, the patient's brain hasn't received the information that the body's been invaded. And as you saw with the open gallbladder and open hysterectomy patients, even those patients do well with pre-incisional ketamine.
So, sir, do you see any role of ketamine in post-operative pain management?
Ketamine post-operatively? I haven't found it necessary. I'm sure that, as a matter of fact, I know Dr. Moulier is using low-dose ketamine continuously along with intravenous lidocaine to prolong the analgesia. But again, it took me a long time to get into his head about the 50 milligrams of ketamine 3 minutes before incision. And now he's doing it, and it seems to be going better for him. So,
okay, sir.
Yes.
Can the concept of opioid-free analgesia be used for surgeries like neurosurgeries, cardiac surgeries, or more complex and probably more painful surgeries?
Well, again, the issue is you don't let the signal reach the brain. I have a professor of anesthesia in New Jersey who uses propofol ketamine for neurosurgery routinely and major vascular surgery, and another colleague in Tennessee, Brad Worthington, who's using propofol ketamine for major back surgeries, multiple level back surgeries as an outpatient. Another orthopedic surgeon in north of Boston is using this similar approach for total joint replacement. So again, without beating a dead horse, it's just don't let the brain know that the body's been invaded. And when you see it 10 or 20 times, you say, yeah, it has nothing to do with the complexity of the surgery or the level of pain that we perceive. The critical issue is that the brain doesn't know the body's been invaded.
He can't hear.
Hopefully does that make it clear? It's a kind of a repetitive thing, but that's what we've got. And I appreciate the skepticism from which the question arises, and that's why I say if you see 10 or 20 patients wake up with this paradigm, you keep shaking your head. How can something be so simple and solve so many problems? Why have we miss this concept of the invasion of the body. Yes, sir.
Thank you for your nice presentation. I would like to ask you just one question.
Yes.
I noticed that you still using Vioxx, which is rofecoxib, which is, I think it's withdrawn long time. You still using it, or just as a documentary medications? Vioxx is withdrawn long time because of its cardiovascular effect. You still use it?
Precise. Well, I can't use it. The point I was making is that when it was available, I used it, and I thought I was seeing improved patients. And when it came off the market and I wasn't using it, I didn't see any difference. So whether you're using Vioxx when it was available or Celebrex now, you know, yeah, you can make something more difficult. You can always give more drugs, but if you can achieve the same or better effect with a simpler approach, it makes it harder to mess it up.
Okay, thank you.
For example, during the rhinoplasty, how can you control the blood pressure? Surgeons, they are asking for hypotension during their anesthesia for rhinoplasty, septorhinoplasty, for example. How can you control the blood pressure with decrease the blood pressure without, for example, remifentanil during the anesthesia?
My first line of attack, if the high blood pressure is accompanied with rapid heart rate, is propranolol, 10 milligrams. And I give 10 milligrams at once because I don't have opioids, which tend to predispose to bradycardia. And my second line of attack is hydralazine, 10 milligrams. So there's many ways, aside from nitroglycerin or nitroprusside drip, to control hypertension.
Yeah, but how, for example, can you control the agitation or laryngospasm during the emergence from anesthesia? Sometimes, especially if you give ketamine, we notice that the chance of laryngospasm may be more if you give, for example, something different than ketamine.
I think the microphone is too close. I can hear that you're speaking, but I'm having a hard time understanding what it is you're asking.
My question is, if we need calm extubation, the patient be extubated without laryngeal spasm or agitation in the emergence for after the extubation. In the extubation period, some patients, especially after ENT operations, they need more, the extubation should be without laryngospasm or without.
Right. Well, you can give the lidocaine preemptively before you take the tube out, but you have to remember, in 26 years, I haven't had to intubate anybody, so the closest thing I have is the ontubation of a laryngeal mask airway, which is substantially less stimulating to the trachea. So I don't want to beg the question, but I can't tell you much. I remember in the old days when I was intubating patients, I would give them 100 milligrams of lidocaine and hope that would smooth things over for the extubation.
Okay, so you are depending on lidocaine instead of opioids?
Yeah, no opioids.
No opioids?
No.
Okay, thank you.
Not helpful.
Thank you.
Sure, thank you.
Concerning the intermittent technique for local anesthesia infiltration, is it suitable with your technique for opioid-free anesthesia? They infiltrate a large amount of saline mixed with local anesthesia. It's called intermittent technique. Mostly in North America they are using. Are you using the same technique?
Very much so.
Liposuction, for example?
Yes. The plastic surgeons refuse to acknowledge Jeff Klein's contribution, and so they call that cocktail wetting solution. The non-plastic surgeons, the cosmetic surgeons, call it Klein solution. 1,000 milligrams of saline or lactated ringers, 500 milligrams of lidocaine, 1 milligram of epinephrine. We use that for everything except for blepharoplasties and rhinoplasties, which require a higher concentration for effective analgesia. And so you're only using a small volume, it's not really a problem. I took out the slides that talked about the different ways we can use tumescent anesthesia. And the irony, of course, of tumescent anesthesia, as Jeff Klein related at a meeting, is that he invited the local anesthesiologist before this invention to come give anesthesia with an anesthesia machine, and the plastic surgeons at the local hospital said, great, go ahead down there, but we'll never do another case with you. So Klein was deprived the ability of having general anesthesia, so he sat and figured this out, and the plastic surgeons created their own monster because now the cosmetic surgeons can do cases in the office and not have to bother with trying to get hospital credentials where the plastic surgeons sit who approve or not approve. So it's a very interesting situation, and what can I say? There's no peace between the cosmetic surgeons and the plastic surgeons.
Yeah. One more point.
Yes.
The use of ketamine, you have long-standing experience. Do you have cases of cystitis?
No.
You don't?
No cystitis with the use of ketamine.
You didn't.
We're only talking, when I looked at 1,000 cases that I did, logged, 80% were done with 1 or 2 50-milligram doses. Most of the reason for the second dose was in the early days when the surgeon would only inject one side of the face because he was afraid the anesthetic effect would wear off. It's simply not true. And once I was able to encourage them to inject both sides or both breasts or, you know, the breasts and the tummy for the mommy makeover, I was able to keep it to 50 milligrams. It's hard to get cystitis from 50 milligrams, but it was a good question. Thank you.
One more, yeah.
Thank you very much for a wonderful lecture, and
Thank you.
a lot of questions and aspects, of course, you have covered, but one point I want to make, or one question I have. Back in let's say early 2000, okay, BIS became very popular with our hospital practice as well, and a lot of people, or most, were using BIS. And I generally practice minimal relaxant anesthesia or no muscle relaxant anesthesia.
Excellent.
And so I noticed that when I put a BIS, and I have given a single muscle relaxant dose for intubation, say for, and then the BIS value is greatly different when there is a muscle relaxant used and when the muscle relaxant is not used. It would sometimes vary between, say, 60, it would be showing 60, and post-muscle relaxant, it can drop to 40 suddenly, okay? Because
this has been reported, yes.
Now, in your practice, since you are practicing non-relaxant anesthesia most of the time and your patients are spontaneously breathing,
right,
you have a baseline established, and that baseline doesn't vary much. So it is more easier to track that closely. But if one has to use a muscle relaxant, then the baseline is obscured. You don't know which one to rely on to give any TIVA method. So do you have any comment on that or any experience on that?
Well, as you accurately point out, it's a little out of my area of expertise, but I would ask you if you were trending EMG along with the BIS, because that may be able, you may be able to figure out what's going on. Again, I can only tell you what my friends who do cardiac anesthesia, who paralyze the patients profoundly, they say EMG spikes continue to persist. And again, the engineering trick that they did with putting the superficial signal from the forehead on the same screen as the BIS signal, which is deep in the cortex, was, it's an infinitesimal signal. I think maybe once or twice in 20 years I saw the eyebrows actually move with an EMG. You don't see movement of the brows at all.
So I completely agree for the scenario where you have completely non-relaxed and completely relaxed, because in both there is a well-established baseline.
Right.
My concern is when it is relaxed at some point and then not relaxed, and that's where your baseline goes haywire.
Right. Well, the point again is that without that EMG, you don't really have a real-time signal. You know, you may be seeing a drop in the BIS, but it may not, you know, if you wait a few minutes, it may just come back up to where it happened. Again, I wish I could speak more to it, but I
Any
don't
more
really.
question?
Thank you. Okay, thank you for the question.
Okay. Thank you, everybody. You here? You didn't tell me.
I just want to ask you one thing. In your practice, you have never used rescue analgesia in the post-operative period, and if one has to use, what would you advise?
Well, many times intravenous ketorolac can be effective, but just as often as not, 1,000 milligrams of acetaminophen when the patient wakes up and says they're uncomfortable. Again, that's predicated on whether or not they've been lying still or they've been squirming during the case. Obviously, the patient who has not been very active at all during the case really needs some tranquility to go along with the analgesia. And so I worked with one surgeon who just insisted that he had to give these patients fentanyl, and you know what it's like to argue with a surgeon. It's a losing proposition. So I let him have his way, and he was a happy boy, and we don't work together anymore. But yeah, it's so profoundly different than what you're used to seeing that, I mean, you have to experience it. And the people you'll hear from first are the recovery room nurses. They're going to come to you and say, "What are you doing differently, doctor? These patients don't even look like they've had surgery. What are you doing?" And that's how you know you've hit the mark. That and the absence of EMG activity with that skin incision or local anesthetic or trocar puncture, now you know that you've protected the brain and you're not allowing that patient to suffer when you think they're okay. Makes a world of difference.
Okay. Thank you, everybody, and see you next month, inshallah. And